As a valued NEI podcast listener, get $100 off NEI Fall Congress registration with code POD26. That's POD26. Go to nei.global/fall, FALL, to sign up today. Early bird rates end on June 30th. Register early before it sells out.
Welcome to the NEI Podcast. In this episode, we present a series of extended Q&A sessions recorded at the 2026 NEI Spring Congress in Kissimmee, Florida. Faculty members who presented at the Congress address unanswered questions from selected presentations, offering insights and clinical takeaways. Stay tuned for thoughtful and informative responses from our expert faculty.
Hello and welcome. My name is Dr. Jeffrey Strawn, and I'll be answering your questions about my presentation From Avoidance to Action, Evidence-Based Pathways to Recovery for Difficult-to-Treat Anxiety. Let's get started. A very important question that was asked was, what do I think about difficult-to-treat anxiety in the real world? In other words, what does it actually look like? And probably most importantly, how does one distinguish that from incomplete initial treatment trial? Well, as we talked about in the presentation, difficult to treat anxiety can often be because of a number of factors, including, unfortunately, many factors that we are responsible for as clinicians. So on the therapeutic side, when we're thinking about medication, this can certainly be things like underdosing, or an inadequate duration of a treatment trial. On the therapy side, it can also be a number of things related to the cognitive behavioral therapy or the other type of therapy. One of the things that we often see is that there's really no exposure-based component of the psychotherapy. And one of the things that we know is that having those exposures is very, very important because it does a couple of things. Number one, and probably most importantly, it allows the patient to see that they can tolerate the distress that comes from doing something uncomfortable or something that produces anxiety. Again, the goal here is almost like vaccination, providing a little bit of something that produces an immune reaction, or in this case, an anxiety reaction, in the hopes that it attenuates later anxiety or later conditions that may be prevented by a vaccine in this case. Now, when we're thinking about cognitive behavioral therapy, one of the other things that we often see, and this is where we can really borrow from the pediatric literature, is that oftentimes therapists will engage in what we call safety-seeking behaviors. So this may be something like providing excessive reassurance, or really because of our own ability as therapists or psychiatrists or psychiatric clinicians to tolerate anxiety, trying to do things in the moment to significantly lower the anxiety. Another question was, when a patient isn't responding to a first-line treatment, what are the most common reasons things aren't working that clinicians can perhaps address? And this is probably a nice follow-up to our initial question. Thinking about it from a medication standpoint, one of the things that we'll often see with the SSRIs is that a patient may experience some improvement, but they're not quite getting to the finish line. And oftentimes, this is where we do consider dose. Now, for some of our SSRIs, we do know that there's a lot of variation in metabolism. For example, for escitalopram, citalopram, sertraline, we know that those are heavily metabolized via 2C19, cytochrome 2C19. And we know that there's also tremendous variation in the population in terms of activity for that enzyme, with some individuals being slow metabolizers and some individuals being ultra-rapid metabolizers. So if I have a patient, for example, who's treated with escitalopram, and they're treated with 20 milligrams, and they've received some improvement, but really not crossed the finish line in terms of remission and are not experiencing any significant side effects, that might be a situation where I'd consider pharmacogenetic testing, specifically looking at cytochrome P452C19. Now, if that patient were to turn out to be an ultra-rapid metabolizer, one of the things that I would know is that that's a patient who, at 20 milligrams, has less escitalopram in their blood than I would expect compared to a normal metabolizer. So that patient actually needs about 30 milligrams of escitalopram in order to generate the same blood level as a normal metabolizer would have with a 20 milligram daily dose. So that's probably providing some rationale for titrating the dose beyond the FDA-approved maximum dose of 20 milligrams. Another thing that is particularly important is that many of our patients will take medication intermittently. And we know that with many of our SSRIs, just missing for 2 to 3 days can actually precipitously drop concentrations of the medication, in fact, nearly to zero, particularly if the patient's an ultra-rapid metabolizer of 2C19 and they're taking escitalopram or sertraline. Another factor that we should consider is in terms of patients who are using cannabis or other substances, and one of the things that we know is that those other substances can have both pharmacokinetic as well as pharmacodynamic interactions. We know that cannabis, based on some of our modeling studies, can affect activity of certainly 1A2, but also of 2C9 and 2C19. And so what we see is that in patients who are using certain SSRIs and cannabis concurrently or concomitantly, we'll see greater peak-trough variation, and we'll also tend to see differences in terms of exposure. Now, that may look like differences in terms of side effects for many of our patients, and particularly those side effects which we associate with the SSRIs. The other thing that we will see in terms of patients using cannabis and an SSRI is that there's likely myriad pharmacodynamic interactions. In other words, things that are being done by the various moieties within smoked cannabis that may be interfering with the target of the SSRI. Now, speaking of cannabis and anxiety, there was a question related to patients with difficult to treat anxiety who are using cannabis and how we think about potential rebound or worsening anxiety over time. And this is something that actually has been evaluated in 2 or 3 prospective studies. And what has been found is that patients who are using cannabis, while some may experience a bit of relief temporarily, many will experience worsening anxiety over time. One of the other things that's important in terms of our patients who are using cannabis is that while that cannabis use in the short term for some individuals may produce some relief in anxiety, what it also does is it perpetuates avoidance. And I think that's something that's very, very important as we think back to the avoidance cycle that ultimately maintains anxiety for many of our patients. Now, one of the other things that's really important in terms of thinking about cannabis is that we know that cannabis will decrease the activity of neurons within the ventral tegmental area. And that decreases both dopamine release as well as dopaminergic neuron firing. That's important when we think about the various roles of dopamine within the prefrontal cortex and within the CNS in general. We know that dopamine is one of the primary neurotransmitters that subserves motivation and reward. And if we look at some what I think are very interesting PET studies now done a number of years ago, what we find is that not only does it decrease dopamine firing and dopamine release, but it also decreases dopamine synthesis. And so now I may set up a scenario in which my patient who's chronically using daily cannabis experiences more withdrawal from various situations, and there's less of a tendency to engage with others or to engage in things that may involve a little bit of risk or anxiety, but also some potential for pleasure and enjoyment. What I've also found is that for many of these patients, this imparts a degree of SSRI resistance, if you will. Another question asks, in terms of my highlighting that not all CBT is created equal, and what should clinicians be looking for in terms of whether or not a patient is actually getting exposure-based therapy? Well, there are a couple of things that I think are very helpful to look at. Number one is what is actually happening in session. Number two is how frequent are those sessions? Number three is, are things happening that involve exposures outside of sessions? So in other words, is the patient being asked to engage in some situations or think about things which produce a bit of anxiety or distress, and learning really to tolerate that? We also mentioned the important role of safety-seeking behaviors within the individual session. And that's something that's very important because that's something that is previously been shown to decrease the effectiveness of CBT. Another question was related to patients with partial or no response to an SSRI or SNRI in terms of how we would think about the next steps, in terms of when to optimize, when to switch, or when to augment. And as I'm thinking about patients with no response, so in other words, zero improvement with an SSRI or SNRI, if we've in general not seen any improvement, none, zero, nada, zilch, by week 8, there's a very low likelihood that we will magically see improvement over those next 4 or 8 weeks of treatment. So that's a situation where I would switch horses a bit earlier. Now, if that patient has started to see some improvement over time, that's a situation where I would titrate the dose of the SSRI or SNRI. In patients who have gotten some improvement, but perhaps have persistent symptoms, I would think about those persistent symptoms. So is that persistent symptom avoidance, in which case it may be best targeted by a cognitive intervention or an exposure-based intervention? Is that ongoing symptom persistent rumination, in which case that may be a patient wherein I would use adjunctive buspirone? Or is that an individual who has prominent autonomic symptoms, in which case that might be an individual in which I would consider propranolol? Another question was related to my thoughts on long-term benzodiazepine use. And the person asking this question noted that it is sometimes necessary in certain patients. And how do I approach conversations with this around specific individuals? This is really a great question because one of the things that we tried to highlight in the presentation was the fact that use of benzodiazepines can be very nuanced. They are not like any other medication, all good or all bad. They have a specific role, and that role may vary from patient to patient, and it may vary within the same patient from the beginning of treatment to the end of treatment. One of the things that I think is always important when we're thinking about chronic benzodiazepine use is, are there things that are red flags? Is there concern for abuse or dependence? Or are we starting to see cognitive decline? Or are we starting to see falls? Or are we starting to see some things that maybe could be a relative contraindication or some signal that we should really carefully reevaluate our benzodiazepine use? Another thing that I would probably add to that list would be if we are seeing a pattern of significant titration of the dose over time. When we look at the long-term data related to benzodiazepines, one of the things that's really interesting is looking specifically at individuals with anxiety disorders. We often find that the dose of the medication remains stable over very, very long periods of time. That being said, if the patient and clinician are on the same page in terms of trying to discontinue the benzodiazepine, I think when and how to do it is something that is very important. And this is something that we've written about pretty extensively over the past several years. So one of the things that I always try to do before pursuing a taper is to make sure that I have optimized everything that ensures a successful taper. That includes making sure that I've addressed co-occurring conditions, that sleep is under control, that things are going well with regard to the anxiety. One of the things that we know in particular is that high pre-treatment anxiety is associated with a worse outcome when we do try to taper the medication. Another thing that's very important is in terms of patients' individual beliefs about the medication. One of the things that we know is that patients who attribute more of the improvement to the actual medication as opposed to themselves are individuals who are going to have a rougher road when it comes time to stop the benzodiazepine. I want to now thank you for joining me today. I really appreciate these thoughtful and excellent and thought-provoking questions, and I hope this discussion was helpful for your day-to-day practice.
Are you looking to stay current in psychopharmacology without falling behind? Well, NEI membership gives you on-demand access to expert-led education, practical clinical tools and resources you can use right away. From master psychopharmacology content to patient education materials and CME opportunities, it's all in one place. Join thousands of clinicians who rely on NEI to sharpen their skills and improve patient care. Learn more at NEIglobal.com.
Hello, I'm Dr. Christoph Correll. In this session, I will be addressing key clinical questions that came out of my presentation titled, Perhaps the Grass is Greener. Why, when, and how to switch or combine treatments for schizophrenia. Let's go into these questions. First question was, when you're seeing a patient who's not doing well on their current antipsychotic, how do you determine whether this is true non-response, partial response, or intolerance? And how does that guide your next step? This is not always easy, so in that sense, it's a really good clinical question. True non-response really means that you have patients on a therapeutic dose that they can tolerate and that they're actually taking it. So pseudo non-response would be when patients, unbeknownst to you, are skipping every other dose or basically take it very irregularly, forget doses. And that means you have to always ask about it. But if you're not sure, and particularly in patients who are doing well on an inpatient unit where medication intake is supervised, and then once they're on the outpatient basis get worse again, this is more of an indicator that patients are partial or poor adherence patients. And if that happens, then switching to a long-acting injectable may be the right way to actually test whether this is pseudo-resistance or non-response or true non-response. Partial response is another interesting component of our care of people with schizophrenia because it's very common. We may have some improvement, but not the full way. We also need to consider what the response are we looking for. Is it positive symptoms? Are we also looking for negative or cognitive symptoms? And could this partial response or non-response be due to side effects, secondary negative or cognitive symptoms, for example? So you want to treat MDD if they have depression, which can give you social withdrawal and also pseudo dementia. You may want to treat anxiety disorders or particularly social anxiety, panic disorder, because people might retreat into their home and it's not really true negative symptoms. Also, residual positive symptoms can lead to secondary social withdrawal, so make sure you're addressing that. And what about side effects? Too much sedation, too much extrapyramidal side effects or weight gain can all have a bad effect on cognition and also motivation and activity levels. Ask about sleep, because when patients have interrupted breathing and snoring, they might have sleep apnea, which can happen also with weight gain secondary to our antipsychotics. And when you don't have enough oxygen during the night in your brain, obviously the day will not be a good one. And that brings us also to the intolerance. You have to ask about it. And I actually prep patients which side effects could happen so that they're not caught off guard, especially people in their early phase of the illness, because then non-adherence is much more common. And then once you've established this, that determines who you switch and how to switch and where to switch to. So if you have an intolerability switch, you know to predict much better than for efficacy which medication might avoid that certain side effects, and you try to go there. For inefficacy, we do know that maybe some of the safer drugs are not always that effective, at least in meta-analyses, like partial agonists, for example, than full antagonists. Some patients might need a fuller antagonistic effect, but even partial agonists, the higher you go on the dose, the more antagonistic they become, functionally at least. And then olanzapine, which may not be a first-line treatment because of cardiometabolic side effects, is very good for efficacy. Now, olanzapine samidorphan might curb off some of the weight and metabolic effects, and you can bring it earlier into the mix. But certainly, if there's true non-response and resistance, then a switch to clozapine may be the right thing to do. And before that, to rule out pseudo-resistance, you could go for a long-acting injectable. Second question, in patients with partial response or tolerability issues, how do you decide when to move to an LAI versus continuing to adjust oral strategies? Well, as I mentioned, if you suspect pseudoresistance, if you suspect or are able to ascertain that the patient is not taking the medication regularly, then long-acting injectables are really the right way, rather than going from switch to switch, oral to oral. Actually, I would say that giving a long-acting injectable option early, even before non-adherence occurs, is also very evidence-based, and particularly in early phase and first episode patients that have the most to gain and the most to lose. We know that their adherence patterns are worse than even in chronic patients because they haven't yet learned that maintenance treatment is necessary. They may have problems with accepting that they have the illness. They put hope over hope and think that, it was just the stress or the marijuana, rather than accepting that schizophrenia. So not waiting too long for LAI treatment or clozapine can really make a big difference. Third, you mentioned that switching can sometimes become a trap. When do you start thinking that repeated switching isn't the right strategy anymore and something else is needed? Well, you need to look at the trajectory of the patient. If switch after switch, they have either one side effect compounded on another, you may have to rethink this thing and find the right dose or the right treatment for the patient that is semi-categorically different. You may need some co-treatments that are non-antipsychotic treatments to make the antipsychotic more acceptable. If there's some akathisia, propranolol is maybe a treatment, or a benzodiazepine. And also, if you have weight gain that is problematic, well, add metformin. Actually, you might want to use metformin preventively once the patient shows that they have initial weight gain. And also, what about GLP-1 agonists that are much more powerful than metformin to mitigate that kind of side effect? You might also make sure that you want to add a partial agonist like aripiprazole when there's hyperprolactinemia, and the patient doesn't do better when switching from a full dopamine antagonist, and you may need to go back to that was effective, but the switch for the side effect didn't really work. So adding here and having polypharmacy is evidence-based based on also meta-analyses. And then the switching among antipsychotics, oral antipsychotics for partial response in efficacy. Here again, looking for a long-acting injectable trial to weed out the pseudo-resistant patients, and think early of clozapine, which at the moment is the best treatment we have for resistance. But then also getting out of this collateral switch with the same mechanism of action. Now, since 2024, we have actually muscarinic modulator available to us, the M1, M4 agonist xanomeline, paired with the peripherally restricted anticholinergic trospium chloride, which is a presynaptic dopamine modulator via modulating with acetylcholine, GABA, glutamate, and then also dopamine. So some patients might have an EI imbalance, excitation and inhibition imbalance, and might need a strengthening of the GABA effect that then drives down glutamate. And via glutamate reduction, top down, you get less presynaptic dopamine. Our postsynaptic dopamine blockers don't do that. And they also might actually block presynaptic dopamine receptors, keeping some of the presynaptic hyperdopaminergia in place rather than in check. And that might be partly due, one of the reasons why patients also have treatment resistance or partial response to our current dopamine antagonists. So here, switching to a presynaptic modulator, muscarinic M1, M4 agonist xanomeline trospium, could be a very good strategy going outside of class, as we think that going to clozapine is also an outside of class kind of a switch. But obviously clozapine has much more baggage in terms of needing blood work frequently and having potentially serious and severe long-lasting side effects, whereas xanomeline trospium may have some procholinergic nausea, vomiting effects early on, and also anticholinergic effects, dyspepsia, as well as constipation. But those seem to be mostly short-lived in the first 1 to 3 weeks. And we now know that faster titration to the full dose, like done in the acute studies, even in outpatient care, is the right thing to do when you switch or when you add xanomeline trospium to current antidopaminergic agents. You need to go to the 125/30 twice a day without food, an hour before or 2 hours after food, very quickly, because that ratio determines that you have less intolerability with this new class of medication, when a switch outside of class might be the right thing to do. Fourth question, when you decide to switch, how do you think about cross-titration versus a more abrupt approach in real-world practice? Well, I would add to this that I have cross-titration and delayed cross-titration or abrupt change. Now, an abrupt change generally is not needed. Maybe in a setting where you need to act very quickly, inpatient, yes, you may be able to do that. You also then have much more monitoring availability and nursing staff that can tell you whether the patient is tolerating this abrupt switch or not. And you can use benzodiazepines to mitigate some of these rebound phenomena that can happen when you go from more to less or from short to long. What do I mean by that? I mean pharmacodynamically, when you go from more blockade to less blockade, you have upregulated receptors that can then, when you liberate them, be hit by the endogenous neurotransmitter. That means when you go from tight D2 blockade to looser binding or to partial agonism, don't do an abrupt switch. Don't even do a cross-titration. Do a delayed removal of the first antipsychotic. Same when you go from a Payne to a Done or a PIP or even the muscarinic agonist, because here you have histaminergic blockade. And when that is liberated, you can get, instead of sedation, agitation, insomnia, and that's not a good thing. So in that sense, making sure that you only do a cross-titration that is going down on drug A at the same pace that you're going up on drug B when you go same to same. PIP to PIP, partial agonist to partial agonist. Payne to Payne, that's sedating to sedating drug. Or Done to Done, tighter binding on D2 to tighter binding on D2. And then I mentioned also, you want to be careful when you go from short to long. That means when you have a shorter half-life drug that comes off the receptor during a cross-titration much quicker than the new drug can build up and get to the same postsynaptic dopamine blockade, you can get a gap. And that gap, again, can get you more agitation, psychosis, restlessness, and withdrawal symptomatology. So when you go particularly to the partial agonists that all have longer half-lives from all the other drugs, you have to do a plateau cross-titration. Build up your longer half-life drug. Wait for 5 half-lives, ideally, maybe 3 as the shortest. And then when you have reached that steady state, only then go down on the more tightly binding drug, on dopamine or a full antagonist drug, I should say, on dopamine or histamine, and also the shorter half-life drug. Whenever you come from ziprasidone or quetiapine immediate release, those are short half-life drugs. Or when you come also from the muscarinic agonist, that's twice a day dosing. So you don't want to there do a cross-titration. You need to really build up your new drug first before you bring down the shorter half-life drug. How do you think about, fifth question, when combining therapy is appropriate in schizophrenia? And how do you avoid unnecessary or prolonged polypharmacy? Well, you have to first make a decision up front. Do you feel that the current treatment is partially helpful? Do you feel that it's tolerable? If that's both true, then maybe adding a treatment to do combined efficacy attempt is something you can try. But very often we switch because we're unhappy with the prior drug, either in efficacy, well, maybe you want to complete the full switch, or in tolerability, take that drug away so that you don't have lingering effects. But you may want to do this with an overlapping switch, as I said. So you have timed polypharmacy. You tell the patient that this is your goal. You want to do the full switch. It's only an overlap to reduce side effects, not to increase side effects. Set expectations for yourself, for the patient. And then that is sometimes the position that, oh my God, I'm adding something. I haven't taken away the first drug, and the patient suddenly gets better. Maybe it's expectation and hope. Maybe it's just the new drug is kicking in. But very often we then feel, oh my God, it's the combination that does it. So let me not rock the boat and abort my cross-titration, abort my switch. I wouldn't do that. I would try to stick with the initial plan and prove that this combination is what does it, rather than that the new drug does it. And for that, you need to continue the switch very carefully to the new drug, which gives you the opportunity to actually take away the prior antipsychotic with their side effects that could interfere. So it's very important that you stick to this rule. But there might be patients where you want to add it on to augment the efficacy of the first drug, or to actually take side effects away, like adding a partial agonist to a full antagonist for prolactin elevation. You might want to have a drug that helps with sleep architecture, or also some effect on negative symptoms, like adding cariprazine with D3 modulation. But again, under the auspices of dopamine blockade of the other drug, these effects might not fully unfold. So maybe you do a partial switch versus combination by adding a drug and then reducing the dose of the first medication, capitalizing on the combined efficacy on the dopamine system, but reducing some of the side effects of each of the drugs. But we need much more information until we know which polypharmacy works. And we also need more information how postsynaptic dopamine blockers with presynaptic modulators, the muscarinic modulator class, actually interact. Data are not entirely clear. Subgroups of patients not on risperidone did do well when xanomeline trospium was added to the dopamine antagonism, but quetiapine and olanzapine were not in the mix because they have also peripheral anticholinergic effects. So we need to learn more about this, but the positive symptoms did improve with combinations, at least in some patients. And there might be even a waking up effect with the M1 stimulation of the cortex to get more cognitive effects, but that might be stronger when you're able to reduce the dose of the dopamine antagonist or even complete the switch. More to come with more switch studies, both in clinical practice and real-world evidence, but also randomized trials. And now the final question, how do you decide when a side effect like hyperprolactinemia becomes clinically meaningful enough to outweigh the benefits of an otherwise effective antipsychotic? Well, remember, we are not treating numbers and lab values, we're treating patients. When you have someone on paliperidone, on risperidone, on haloperidol, prolactin will be increased. Usually, endocrinologists just become worried when you have triple-digit prolactin levels, not double-digit, but they're already elevated. We're not treating numbers, we're treating patients. So you need to ask patients whether they have sexual or reproductive side effects. So for women that are in the childbearing age, here galactorrhea, they may not even know what that is. Like nipple discharge is something you need to ask about. What about oligomenorrhea, amenorrhea? Amenorrhea is not to be accepted if it lasts for several months because that's not good for bone density, and there might even be a higher risk of breast cancer. Then we have sexual dysfunction, libido decrease in males, erectile dysfunction in males and females, also a problem potentially with reaching orgasm. And when that happens, patients can get scared. Will that always be the case? It might reduce their motivation to take medication. It might also mitigate the pleasure and enhance negative symptoms. So we want to be careful with that when it interferes with functioning, when patients get distressed. And then you either need to switch or, as we mentioned before, add maybe a partial agonist, 5 to 15 milligrams of aripiprazole, and then within a week or two, you actually have almost normalized prolactin levels. But there might also be sexual side effects that are independent of prolactin elevation, might predate that drug, might have to do with relationship issues or anxiety, and that might be then amenable to psychotherapy. Well, thank you for joining today. I hope these answers provide practical guidance as you think through similar cases in your own clinical work when it's about switching antipsychotic agents and optimizing care.
Hi, I'm Dr. Jennifer Payne. Thanks for joining me. I'll be going through some of the great questions that came up after my session, The Other Side of Motherhood, Advances in the Treatment of Postpartum Mood and Anxiety Disorders. Let's get started. Number 1, how do you distinguish postpartum blues from postpartum depression in real-world practice, especially when symptoms don't follow a clean timeline? Well, I think the biggest differentiator between postpartum blues and postpartum depression is effects on functioning. And that's kind of true for psychiatric illness across the board. But a woman can have mood lability, tearfulness, and feeling like she's having emotional swings, but still function at home, can still take care of the baby, can sleep some when the baby's asleep. Whereas postpartum depression really meets full criteria for a major depressive episode and has clear impacts on functioning. In addition, any woman that's having really severe symptoms, so suicidality, thoughts of harming the infant, feeling not attached to the baby, you really want to be thinking about postpartum depression. Number 2, you emphasize the importance of ruling out bipolar disorder. What are the key red flags in the postpartum period that should make clinicians pause before starting an antidepressant? Probably the number one factor that I look for is a family history of bipolar disorder. Certainly, when someone has a history of bipolar disorder, you should not start an antidepressant unopposed by a mood stabilizer, even if the woman is presenting with postpartum depression. But if she has a family history of bipolar disorder outside of a personal history, you should also think twice. I also think when patients are presenting with mixed symptomatology, so a low mood, but feeling very energized, having trouble sleeping, lots of irritability, you should think twice and definitely screen for bipolar disorder. Number 3, we know that premenstrual dysphoric disorder and postpartum depression both seem to involve a heightened sensitivity to hormonal fluctuations. Does having PMDD before pregnancy actually increase a woman's risk of developing postpartum depression? And should that change how we monitor her, or even how we counsel her before she conceives? So absolutely, having a history of PMDD or even severe PMS does increase the risk of developing postpartum depression, but it's not 100%. So there's no guarantee that a woman with PMDD is definitely going to have postpartum depression. It does change how we monitor her and how we counsel her, and that I would follow a woman with a diagnosis of PMDD very closely towards the end of pregnancy and in the immediate postpartum time period to make sure that I'm right on it if she develops symptoms of postpartum depression. I also counsel her that she's at an increased risk of developing postpartum depression. Number 4, for a patient with postpartum depression and no prior treatment history, how do you decide between starting psychotherapy, medication, or both in a real-world practice? That's a great question. So first and foremost, I think it's important that all patients understand that the combination of psychotherapy and medication has the most evidence for treatment, response, and remission. However, there's some real-world scenarios in which a woman cannot do psychotherapy. If she does not have home support to take care of the child, it's going to be very hard for her to do regular weekly sessions of psychotherapy. It's a little bit easier these days with the online psychotherapy that's available, but it's still hard to do a really good psychotherapy session with a crying baby who wants to breastfeed. And so I basically do an education of the patient and educate them that the recommendation is psychotherapy plus medication, but recognize that not all women are going to be able to do it. In addition, women need to have insurance coverage to support covering psychotherapy. And if she doesn't have that insurance coverage, psychotherapy is often off the table. Number 5, with the availability of zuranolone, how are you thinking about where it fits in practice? Who is the right patient, and when would you reach for it? So I reach for it in a couple of different scenarios. The first is a first ever postpartum depression or major depressive episode in the postpartum time period. And the reason why I reach for it then is that it's a quick treatment option, so people often respond very quickly, and it's a limited time treatment option. And it's almost like if you can pop them out of that depressive episode, they will stay well for a longer period of time. So a new first onset of postpartum depression is a scenario that I think is very likely to respond to zuranolone and then not require ongoing antidepressant treatment for the long term. I also reach for it when a woman has been taking an antidepressant in pregnancy and then either gets depressed postpartum or worsens in the postpartum time period. I will continue the antidepressant therapy that she's been taking and then add zuranolone for that 2 weeks of treatment to try to get her out of the depressive episode and then allow the antidepressant to continue working for the long term. Where I don't use it is for a depressive episode during pregnancy. Currently, we do not recommend the use of zuranolone for postpartum psychosis. The one other thing that I would recommend thinking about is when a woman is presenting with lots of anxiety. Zuranolone really demonstrates good efficacy towards targeting those anxiety symptoms. So a postpartum depressive episode with lots of anxiety is another scenario that I think about. And then finally, when someone is presenting with severe symptoms but doesn't want to be hospitalized, doesn't meet criteria for being hospitalized, and you really want to get things going quickly, zuranolone is something I would try in that scenario as well. We know that zuranolone separated from placebo by day 3, and women really report a quick turnaround in their symptoms with the use of zuranolone. Number 6, there's growing interest in the role of estrogen in postpartum depression. Do women with postpartum depression show better responses to SSRIs when estrogen supplementation is added? And is this something you're incorporating into practice? That's a great question, and that's a really great ongoing research question. There was a double-blind, placebo-controlled trial using estrogen to try to treat postpartum depression, and it had to be stopped early because women who are in the postpartum time period metabolize estrogen differently than they do outside of the postpartum time period. And so the trial was not able to achieve the blood levels that were required for the trial. And it did not appear at the time that they stopped the trial prematurely that there was a significant difference from the use of estrogen. I do not incorporate estrogen treatment into my practice at this point. However, I think the questioner is asking a more interesting question, which is, can you use estrogen in conjunction with SSRIs to treat postpartum depression and get a better response rate? And the reality is we don't know the answer to that question. There is evidence in the perimenopausal literature that estrogen treatment or hormone replacement therapy plus SSRIs is superior to SSRIs alone in treating perimenopausal depression, at least in some subsets of women. And so it might be that we could combine SSRIs plus estrogen treatment and get a better response rate. The trouble with estrogen, though, is that it increases the risk for certain medical conditions, including hypertension and blood clots. And both of those are kind of dicey in the peripartum time period. So at this point, I don't think we have enough evidence that estrogen should be added to SSRIs And I think if we pursue a research question and answer it definitively, at that point we could incorporate estrogen. But I would not recommend it at this point. So another question that comes up in my work is, are there ways that we can predict postpartum depression? And it would be nice if we were able to predict who was at elevated risk. And I think that there are a couple different ways that we can do that. Number one, we know that there are a lot of clinical risk factors. So I talked about some of those in my lecture. So having a family history of postpartum depression, a personal history of postpartum depression, having a pre-existing mood disorder, being off psychiatric medications, etc. And all of those can predict an elevated risk of postpartum depression. But again, it doesn't guarantee that a woman is going to be is definitely going to develop a postpartum depressive episode. My research has identified epigenetic biomarkers that are predictive of who's at elevated risk. And to make a long story short, we can take blood in the third trimester and predict with about 80% accuracy who's at elevated risk and who's at low risk. And these biomarkers are associated with genes that are sensitive to estrogen and are involved with synaptic plasticity in the hippocampus. And we think the biomarkers are really biomarkers of central nervous system sensitivity to reproductive hormonal change, putting women at elevated risk of developing postpartum depression. It is my hope that in the future we can use these biomarkers to test women in the third trimester and be able to divide them into a high-risk category versus a low-risk category. And I'd like to emphasize that low risk is not no risk. So women who don't have the biomarkers still need to be monitored for postpartum depression because they may still be at elevated risk for other biological reasons or psychosocial reasons for developing postpartum depression. But the biomarker test identifies a group of women who are very likely to develop postpartum depression. And that allows physicians to make a plan with them during pregnancy as to how they're going to handle it. That can include increased partner or family support. It can include referral to a mental health provider with enough time to get in with somebody. It can include starting antidepressant treatment in the immediate postpartum time period, etc. And it's my hope that these biomarkers will, in the future, be able to be used to prevent the onset of postpartum depression. Another question is, how do you think about designing a treatment plan for patients with psychiatric histories who are on psychiatric medications and want to get pregnant? Well, that is a very common scenario that I see clinically. And I think it's really important to think about each case individually. So women will often come in on multiple psychiatric medications and want to get pregnant in the next 6 months or so and want to know what they should do with their psychiatric medications. So the first thing I do is do a thorough psychiatric history and examination. And assuming that she's well on the current regimen of medications, I really explore how she came to be on that regimen of psychiatric medications. I think every psychiatric clinician has had the experience of having someone be very ill and starting several medications in short succession and eventually getting them well, but not being completely sure if they need the 3 or 4 psychiatric medications that we've started them on. In that situation, I will often recommend a period prior to pregnancy and prior to trying to get pregnant of experimenting with the combination of medications to see what medication is actually needed and if any can be eliminated. The goal for management during pregnancy should really be to limit the number of exposures for the baby. So if 2 psychiatric medications work as well as 4, get down to 2. But if the woman becomes psychiatrically ill, when you go from 3 to 2 medications, go back to 3, because you really don't want to expose the baby to maternal psychiatric illness. I also think it's important to try to use older medications that we know more about. If a woman is coming for a pre-pregnancy consult, I will often recommend that we switch from a newer medication to an older medication if a woman has not tried that older medication and it's not clear that she failed it. The next question has to do with the FDA categories. I said in my talk that the FDA categories are essentially useless. I was being a bit facetious. That's not completely true. But I can tell you that I heard an FDA official give a talk on the FDA categories a number of years ago. And as you may know, there are 5 FDA categories ranging from A to X. So there's A, B, C, and D, and then category X. Category X includes medications that either should not or are not used during pregnancy. Category A is considered safe, and B, C, and D give increasing risk ratings. However, there were originally 6 categories. So there was A, B, C, D, E, and X. And the FDA thought that 6 categories was too many and combined 2 of the categories into 1. And category B includes medications that either have been demonstrated to have limited to no adverse effects in humans, or it includes medications that have only been tested in animal models and did not have adverse effects in the animal models, but there were no human data. And so many new medications, when they first come on the market, are placed into category B. And that applied to a lot of physicians that category B was safer than category C or D, when in reality, we had much more information about older medications that had moved into category C or D because we had human data. And so one common scenario was that when a new medication came on the market and was rated category B, many physicians would switch their patients who were pregnant or wanting to become pregnant to category B. We saw this a lot with lorazepam or Latuda. It was originally category B. And when it first came on the market, a lot of pregnant women were switched to lorazepam in that setting. And the reality was we had absolutely no information in humans. So the FDA categories are confusing, and they have now been replaced with label changes that really try to summarize the entire literature on the safety of that medication in pregnancy, lactation, as well as in humans of reproductive age, meaning both men and women who have the chance of conceiving a child. So read those labels and read recent reviews of the use of medications in pregnancy. That's going to give you a better understanding of what really should be used during pregnancy. Finally, I'll end with reminding you that once a woman is pregnant, that baby is already exposed, and you really shouldn't change to a different medication unless she's on valproic acid or carbamazepine, which should not be used during pregnancy. Once a woman is pregnant, the ship has sailed, the baby's exposed, and unless that mother is ill, you should not be switching medications at that time. Thanks for spending this time with me. I hope these insights give you something you can take back to your patients and apply in your clinical work. Take care.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.